Hello, everybody. Thank you so much for joining our Target webinar today. I can't see any of you, but I know we have quite a few people subscribed, so hopefully they'll join as we begin here. So my name is Emily Cooper. I'll be chairing the session today, and I will be introducing our speakers and panelists in a moment. First of all, just to say this is our 11th webinar in our collaborative series with the RCGP, and this webinar will be discussing managing recurrent UTI and reviewing long-term and repeat antibiotic therapy. You can find our previous webinars on the Target Toolkit on the RCGP website, and once we finish with this webinar, the recording and the slides will be uploaded to the toolkit in the next couple weeks. Following some introductions, our speaker will present for around 40 to 45 minutes, and we will aim to have a 15-minute session at the end of the webinar dedicated to Q&A for the panelists. The chat function is disabled, so please ask any questions throughout the presentation using the Q&A function on your screen. You don't need to wait until the presentation, but you can add questions as you have them. If you wish for your question to remain anonymous, just please tick the anonymous box before submitting your question. And we'll answer as many questions as we can. We do have quite a lot of people joining this webinar, so once we have the webinar finished, we will publish a Q&A that will respond to questions that we didn't get to during the session. Do engage with the polls throughout to aid in your learning. And as mentioned, we will have the recording on the Target Toolkit hopefully up in the next couple of weeks. Also to say, we will have a brief evaluation link that will be shared after the webinar, and it really helps us if you fill this out because we can use the information when we're developing further webinars for the series. Next slide, please, Lee. So this slide, I'd just like to highlight some of the amazing Target and RCGP team who are responsible for the work that underpins the toolkit. A special shout out to Kath and Liam and Joe for the work that they're doing today to see that the webinar runs smoothly, and also to Liam for the work that he put into putting the slide deck together. Next slide, please, Lee. And just to say a big thank you to our speakers and panelists for supporting this event. So all the panelists we're going to have on the webinar today worked as part of the steering group to develop the resource that we're going to be talking through. Special thanks to Naomi and her team in the East of England who've contributed significantly to develop this resource and the how-to series in general that's published on the toolkit. I also need to say a big thank you to the people who supported the development of the Recurrent UTI how-to guide that we're going to discuss today. This includes representatives from multiple professions, GPs, nurses, pharmacists, microbiologists, and also members of the public who participated to develop and review the resource. So without further ado, I'm going to ask the panelists to turn their cameras on and introduce themselves.
Good evening, everybody. Lovely well, not to see you, but to speak to you today. I'm Lee Sanulu. I'm a salary GP in South Wales, and I'm also doing a PhD on the topic of recurrent UTIs. So this topic is really important to me. Thank you.
Hello, everybody. Unfortunately, I can't seem to get my camera on, but my name's Naomi Fleming. I'm the antimicrobial stewardship lead for the East of England for NHS England, and worked closely with Emily and all the speakers on the panel today to develop these resources. Thank you.
Hi there, my name is Avril Tucker. I am an antimicrobial pharmacist in South Wales and have a really keen interest in recurrent UTI management in primary care predominantly.
Hi, my name is Dr. Philippa Moore. I'm a consultant microbiologist at Gloucestershire Hospitals, and I've been working with the team in UKHSA for some time, helping to develop the tools that will be highlighted today.
Fabulous. Thank you, everybody. So Lee, without further ado, I'll hand over to you.
Great. Thank you, Emily. So for the next kind of half an hour, 40 minutes, I'm going to talk through various kind of objectives that we're going to go through. So the first thing that we're going to do is explore from the perspective of both patients and healthcare professionals their experiences and views around recurrent UTIs. Then linking to the recently updated NICE recurrent UTI guidelines, we're going to talk through some of the changes, and we're going to link them to some example scenarios. And we're also going to then talk through the process of reviewing patients on long-term antibiotics for prevention of recurrent UTIs using the Target how-to guide, which I'll talk about a little bit later on. So just to set the scene, first of all, I just want to talk through about why this is particularly important. So what you can see on the right here is a bar chart from the latest ESPAR report. And what it shows is antibiotic-resistant E. coli bloodstream infections. And what you can see with these green bars at the end is essentially what's happened over the last 2 years is that the rates of these infections have increased and they've risen above pre-pandemic levels. Why is this important? So we estimate that around kind of half or 50% of E. coli bloodstream infections are related to the urogenital tract. And after respiratory tract infections, UTIs are the most prescribed, the infection most prescribed antibiotics for in primary care. And this is especially pertinent to recurrent UTIs due to the repeated nature of these infections. So they're exposed to potentially both short-term and prophylactic long-term antibiotics. Particular concern is that we know from research that exposure to just one course of antibiotics increases your odds of resistance on subsequent infections, and this increases the odds by a factor of about just over 2. And unfortunately, this elevation in resistance persists for up to a year, and the more courses, the longer duration of treatment, the higher that odds of resistance is. And just to be kind of clear about what we're talking about today, we're focusing on recurrent urinary tract infections or recurrent UTIs. And this is defined in the NICE guidance as 2 or more UTIs in 6 months or 3 or more in 12 months. So this slide is some research I've done with colleagues a couple of years ago now. And this was a study looking at interviews with patients, but also healthcare professionals around their views and experiences of recurrent UTIs. And the experience from a patient perspective is they describe generally a long history of recurrent UTIs, often spanning decades, with significant impacts on their lives, affecting them physically, psychologically, impacting their relationships, impacting their social lives. And not just during those acute infections, but also in between these infections and the fear of further infections. So it's a significant problem. Patients also describe serious concerns around the use of antibiotics, both short-term and prophylactically, in terms of side effects, but also around resistance, and feel that the non-antibiotic options are maybe not discussed as much as they feel should be, and also there's a need for further research in this area. From a healthcare professional perspective, this was based on studies done in the UK and focused on primary care. The overarching kind of finding was the complexity and the challenge with managing recurrent UTIs in terms of making the diagnosis and not missing a potential serious underlying cause, how to handle treatment failure, but also managing multiple competing interests, from the desire to obviously improve symptoms, manage patient expectation, but also concerns around the use of antibiotics and guidance to obviously reduce the use of antibiotics. A study we published in the summer last year, we did a cross-sectional study looking at the prevalence of recurrent UTIs in Wales, as well as the use of prophylactic antibiotics. And we looked over a 10-year period and found that approximately 6% of all women in Wales over that period had evidence of recurrent UTIs. About 20% of them had evidence of prophylactic antibiotic use. And interestingly, when we looked at prophylactic antibiotic use, not all of those women met the recurrent UTI definition prior to initiation. What this graph on the left-hand side shows is the rate per 1,000 person years according to age. And that what's shown on the red line, there's a slight increase in the rate in early adulthood before plateauing and then rising fairly steeply around the typical age of kind of postmenopausal years. And prophylactic antibiotic use, apart from a lack of a rise in the early adulthood, follows a similar trajectory. Looking specifically at prophylactic antibiotics and their kind of initiation over the 10-year period, you can see that generally the use of prophylactic antibiotics is reduced, but also the proportions prescribed has changed. So lesser use of trimethoprim and cefalexin, likely related to guidance, but also resistance patterns with these, with increasing use of nitrofurantoin. One of the other key findings that was found was around urine culture, and we found that prior to initiation of prophylactic antibiotics, just over 60% had a urine culture reported prior to initiation. And actually, in those that did, a proportion of them, particularly those prescribed trimethoprim, had evidence of resistance against that antibiotic. So brings me now onto the how-to guide, which we've briefly touched upon, but essentially this guide has been published this week, so you can access it via the QR link that's just at the bottom of the screen. And it's a way to try and support during a obviously really pressurized day in clinical practice, so to try and support reviews of patients on long-term antibiotics. So it's got kind of links to relevant treatment guidance, there's patient-facing materials, self-care links. There's plenty of resources as part of that, as well as slides and worked examples around how it might be integrated into a consultation. And as Emily touched upon, this has been developed with multiple stakeholders, from GPs, nurses, pharmacists, microbiologists, and patients with lived experience as well. So over the next 6 months, we're going through kind of a consultation period. So we'd love to get your feedback about the resource, what you find useful, how it can be improved. So yeah, if you could feedback, that would be really appreciated. In terms of accessing the resource, so you can access it via the Target Toolkit, which is located on the RCGP website, and clicking on the antibiotic stewardship link shown at the bottom left of the screen. Within that, you will then see the how-to guides for recurrent UTIs alongside the existing ones for COPD and acne. What I'd like to do now is talk through some hypothetical kind of clinical scenarios, linking them with the updated NICE guidance to try and show how this has changed and how we can implement it in clinical practice. So our first patient is Mei Ling. She's 64 years old. She's postmenopausal and has had 3 UTIs in the last 12 months, so meeting that recurrent UTI definition. She's tried various things herself, including kind of over-the-counter cranberry capsules, which she hasn't found particularly helpful. An examination in terms of her abdomen was completely normal. Just giving a kind of more comprehensive story in terms of her background. So as I said, she's had 3 UTIs in the last 12 months. All have been susceptible to nitrofurantoin, which she's had 3 courses over that period. She's also noticed some vaginal dryness over the last 3 months, but no history suggestive of hematuria. She's not under secondary care services and has been in compliance with kind of the antibiotic courses that she's received. She's concerned that she's getting these frequent urine infections and the fear that they may come back, and actually is impacting her kind of, or making her reluctant, to plan holidays and the impact that they may have in the future. So she's keen to try and prevent further UTIs happening. She's happy to try oral or topical treatments, depending on what would her preferences be, but also would like some treatment for the vaginal dryness as well. So we're going to launch a poll in a second to see what you think. So 4 different options, which will pop up shortly. So just thinking about what do you think would be the best option in terms of to discuss with Mei Ling? So 1 being methenamine, vaginal estrogen, daily antibiotic prophylaxis, or referral to a specialist. So if you could launch that poll, that would be great, please. Excellent. So you just get a couple of seconds now to just respond, and then we'll talk through the updated guidance. Excellent. So, pretty resounding. I don't know if you can see the results, but essentially 80% of people have gone for vaginal estrogen, 10% referral to a specialist, and 5% each for methenamine and daily antibiotic prophylaxis. Brilliant. Okay. So, completely agree with the vast majority that vaginal estrogen is a good option in this case. Obviously, we would discuss some of the other options as well, but vaginal estrogen has potential benefits for the vaginal symptoms that May has described. It's also recommended by NICE for the prevention of recurrent UTIs, although it is off license. As we would do with initiating any kind of long-term treatments or any treatment at all, it's discussing some of the potential risks. Vaginal estrogen is generally absorbed locally. Minimal amount is going to be absorbed systemically, so the likelihood of systemic effects are likely to be small. As part of that, signposting to various patient resources, so NHS menopausal help, for example, and support groups, discussing around adequate hydration and prevention measures, which May is already practicing, as we've talked about, but also talking about the Target Treating Your UTI leaflet, which I'll talk about in a second. So, talking about the evidence for vaginal estrogen. So various trials have been conducted in this area, looking particularly in postmenopausal women, and essentially have shown estrogen, vaginal estrogen, mainly creams, compared to placebo, are effective at reducing UTIs in this population. And that's what this forest plot shows here, although the numbers are small. Then comparing estrogen, vaginal estrogen to antibiotics, results have been slightly mixed, but essentially vaginal estrogen has been shown to be more effective than prophylactic antibiotics at preventing UTIs, whereas vaginal pessaries, the results have been a bit more mixed. And the key finding on this, the lower kind of result is essentially 2 months after stopping the treatment, so prophylactic antibiotics or vaginal estrogen, that beneficial effect of vaginal estrogen disappears, so there's no difference between the two. This is a slightly different study, so it's a retrospective study looking at over 5,000 women with recurrent UTIs that are postmenopausal. And what you can see on this is this black line is when these women were prescribed that course of vaginal estrogen. And what you can essentially see is the mean number of UTIs after that initial prescription then drops by around about 50%. So again, further evidence of the potential beneficial effects of vaginal estrogen. And as promised, in terms of the Target Treating Your UTI leaflet, so there's two versions. You've got one for women under 65, but also for all adults, so including older women as well. And essentially, the leaflet's got various important bits of information around symptoms, around red flags to look out for, ways to kind of self-treat and prevent further urine infection. So a really useful resource. I've used it with my patients, sent it via AccuRx in certain cases, or printed it out. So it is a really useful leaflet, under my experience. So if you were to start Mei Ling on the vaginal estrogen, you would want to review it within the next 12 months, maybe earlier, depending on discussion with May about that. And essentially, during that review process, it's trying to establish, as first of all, has it been effective? Has it reduced the number of UTIs? Are there any side effects that they've noticed, particularly around kind of postmenopausal bleeding and the need to look into that further? To see if it's made any improvement in terms of the vaginal dryness or the vaginal atrophy symptoms that May described. And then at that point, you then may be a case of discussing whether to continue it or a trial off. And obviously that's a discussion individual to that patient. It's also continuing the preventative behaviours that the May is already doing, and a consideration if, unfortunately, the vaginal estrogen isn't effective, considering changing the prophylaxis or adding in another agent. So moving on to our second scenario, so Robert Smith is our second patient. He's a 45-year-old labourer, and he's coming to see you today because this is the second UTI he's experienced in the last 6 months. Again, providing a bit more of a comprehensive story around Robert. So as I said, this is the second UTI he's experienced in the last 6 months, and the particular symptom that's bothering him is nocturia, so frequent urination at night. He does smoke, and he does tend to drink alcohol on the weekends, around kind of 15 to 20 units. Because of the nature of his work, drinking water during the day is particularly difficult, and due to stresses around work, but also the impact of the UTI symptoms, he is struggling at the moment to sleep. He's not under secondary care, And previously, for his previous infection, he had nitrofurantoin 3 months ago, and he completed the course and symptoms settled down. As I kind of touched on, he is having some kind of stress related to his work, but also concerned that this is his second UTI in 6 months and the potential impacts of that. He would obviously like some acute treatment for his current UTI, but also he's worried about ongoing UTIs because he just can't afford to take time off work due to sickness. So we're going to launch another poll again in a second. So to see what you think in Robert's case, what would be your preference in terms of the option to discuss with him? So option A being methenamine, B, a trial of daily antibiotic prophylaxis, C, D-manos, or D, referral to a specialist. So can we launch that poll now, please? Excellent, thank you. So yeah, again, I'll give you a couple of seconds to just have a little think about that one. Excellent, thank you. Okay, so this was a bit slightly more mixed. So I don't know if you can see the results, but nearly 60% said referral to a specialist. Next was methenamine at 18%, followed by D-manos 13%, and then finally a trial of daily prophylaxis at 10%. Okay, so looking at the guidance, obviously you would treat that acute infection as you normally would, but in this case, as Robert is male and as a male genitourinary system, generally the advice would be to refer or to seek specialist advice. Because of the fact that this would be classified as a complicated urine infection, you'd want to send a sample for culture to check or identify for any resistance. But that obviously wouldn't delay initial treatment, but would be important for kind of subsequent infections if they were to develop. And any kind of preventative treatment generally would be guided by secondary care rather than necessarily be initiated in primary care unless advice was sought. In terms of things that we could do is obviously having a discussion around alcohol and potentially reducing that down. That may be beneficial. Ensuring that he's trying to drink more water, particularly during the day. Appreciate the challenges, but see, is there any way to kind of incorporate that into his day in terms of acute treatment, like any condition, analgesia, to relieve any pain, and then exploring around that anxiety around work and the UTIs, and does he need any additional support related to that? So in terms of the urine sample, so the MSU or sending it for culture. So as I said, wouldn't delay treatment for that whilst awaiting it, but would be useful to identify any resistance that may be developing in Robert's case. Obviously, it's having a discussion around how to provide that sample to try and reduce the chances of any contamination. But the key thing is that you wouldn't, there's no real evidence of any benefit of taking a subsequent sample after treatment to test for cure. And actually the risk is that you might detect asymptomatic bacteria and lead to inappropriate further antibiotic use and exposure for Robert. And as we've talked about, the consequences of that in terms of resistance. So this slide just highlights from the guidance in terms of those populations that we need to be thinking about seeking further advice. So as I said, as in Robert's case, men or anyone with a male genitourinary system, recurrent upper urinary tract infections in particular, thinking about do they need further investigation for that. Other populations, pregnant women, children, obviously any symptoms suggestive of cancer should be referred, and anyone essentially who's had any surgery that may affect the urogenital system. Okay, moving on to our third scenario then. So this is Angela. She's 30 years old, she's not pregnant, and she's had recurrent UTIs for a period of time, and she's just completed a 6-month course of nitrofurantoin, which she's taken every night. Fortunately, she's had a really good response to the prophylaxis and has not had any breakthrough UTIs and hasn't noticed any problems with the treatment that she's received in terms of the nitrofurantoin. In terms of a bit more comprehensive background of her history, she's had a long history of recurrent UTIs over the last 10 years. She's not under secondary care, prior to being on the antibiotics had repeated UTIs and courses of antibiotics in the 2 years preceding, is practicing kind of hygiene methods as generally advised, has been compliant with treatment, but is really concerned about coming off the antibiotics and that risk of the UTIs returning to how they were previously. She's willing to trial coming off antibiotics due to concerns around potential long-term side effects, particularly with nitrofurantoin, but would like support in doing so because of this real concern about further UTIs in the future. So we're going to launch another poll. So again, 4 options. So option A being discontinue or trial off antibiotic prophylaxis, B, continue it, C, changing it to methenamine, and then D, referring to secondary care. So if we could launch the third poll, please. Excellent, thank you. So yeah, again, give you a couple of seconds to just have a little think about what you think for this case and Angela's case. Okay, so the majority have gone for option A, so discontinue prophylaxis at 50%, followed by change to methenamine at 26%, 21% refer to specialists, and really low at 2% continuing the prophylaxis. Okay, brilliant. So yeah, I agree. I think having a discussion around discontinuing the antibiotic prophylaxis seems like a reasonable option. Having that discussion about the pros and cons of that, particularly around the risks, especially with nitrofurantoin, and the risks of antibiotic resistance, as we've talked about already. I think really reassuringly, there was a trial published a couple of years ago that included UK patients, women from secondary care with recurrent UTIs, and actually found that just under 50% of them, after stopping prophylaxis, didn't have a further UTI in the subsequent 6 months. So that's reassuring that it's not inevitable to go back to how it was prior to prophylaxis. Again, as we talked about in the previous case, a test of cure or urine culture at this stage isn't required. Again, around prevention advice, there's lots of different options, things like cranberry and D-mannose, and I'll talk a little bit in a second around the evidence related to that. Useful to give Angela a urine sample pot, maybe the necessary forms if she's to get a further UTI, so that sample can be captured. You may want to have a discussion about a kind of a self-start prescription or standby prescription of antibiotics, just in case she does get a subsequent UTI, and to support that trial off antibiotics, a bit like the rescue packs that we sometimes use in COPD. Again, you may want to provide some information around self-management, including the target UTI leaflet that I've talked about a little earlier. Okay, so talking about the evidence for cranberry. So I'm sure that most of you will have seen over the years that the evidence has kind of gone back and forth with cranberry, and it's been fairly mixed. But the most recent kind of Cochrane review does suggest that there is a beneficial effect compared to placebo at reducing UTIs, particularly in those with recurrent UTIs and also children. But it's not universal. So there were some populations in particular, they found no evidence that it was effective. So particularly older people living in care homes and pregnant women. Obviously, the main concern with cranberry is in people who are taking warfarin, although obviously we're using less of that now with DOACs, and also the sugar content as well, particularly in our diabetic patients. In terms of D-mannose, so D-mannose, again, evidence is fairly conflicting. So this first study, published back in 2014, did provide evidence that the D-mannose was as effective as prophylactic antibiotics at reducing UTI recurrence, and was substantially better than no prophylaxis. And that was over a 6-month period. However, a recent trial published last year, done in UK primary care with a large population of women, found no evidence of a benefit over placebo. So kind of complete opposite. And actually, the most recent Cochrane review published in 22 prior to this trial couldn't provide any evidence to either promote or refute the use of D-manners. So evidence is mixed. Some patients may find it beneficial, but it's just obviously being aware that the evidence is limited. And again, because it's a sugar-based kind of compound, just being aware of the risks in our diabetic patients. I've talked about a few times around these kind of preventative actions, so these self-care, self-help things that people can do. And the main one that has evidence is hydration. So there's a trial a couple of years ago showing that in women with recurrent UTIs drinking less than 1.5 litres of fluid a day, just by increasing that fluid intake, it significantly reduced the number of UTIs, reduced antibiotic consumption, and also extended that time between UTIs. So there is a beneficial effect there. Some of the other hygiene methods that are talked about and included in guidance, evidence is pretty limited, to be honest. And the other thing is that actually, if patients are having these discussions repeatedly because they're coming in with infections, that this repeated advice around hygiene can be quite upsetting, and in some cases quite offensive to patients. So it's just discussing that sensitively, and just being aware of the potential negative effects that can have. So if you were to start antibiotic prophylaxis, you'd ideally want to review them within 3 to 6 months to see how they're getting on, maybe sooner, particularly if they're getting UTI recurrences on the treatment. And particularly if they are still getting recurrences despite the prophylaxis, it's thinking, is there another cause for this? Could there be a prolapse, or are they not properly emptying their bladder, so retaining urine that might be causing it? Some of the other options instead of, or the guidance talks about prior to thinking about daily prophylaxis, is whether you would go with a single dose prophylaxis or trigger related prophylaxis, where if someone has a pattern of their UTI, so particularly intercourse being in a trigger, they may want to take a single dose of prophylaxis to try and prevent a UTI. And then same as we've talked about briefly, methenamine as well is another option, which we'll talk about a little bit later. And then again, in those patients where they are continuing to get UTIs despite prophylaxis or after cessation, then you may want to think about discussing or referring to urology if they've not had investigations recently. So in terms of the guidance and when to consider prophylaxis, so as I kind of touched upon, generally the advice in the guidance is to consider them after vaginal estrogen, trigger-related or single-dose antibiotics or methenamine, or obviously where those are maybe not appropriate. And as we've touched upon, kind of review every 6 months to make sure that it's working. Obviously talk about the potential long-term risks and side effects, and also as I touched upon just a second ago, discussing around kind of self-help, but discussing that sensitively. And you can see in the table the doses, but obviously you can get that from the BNF or the guidance. So if you've got someone on antibiotic prophylaxis and they do get a breakthrough UTI, how can we kind of manage that? So as I've kind of touched upon a couple of times, urine culture is really important. One, to see if they've developed resistance to that prophylactic antibiotic agent, and maybe you need to think about changing it, but also to guide subsequent acute treatment. And generally the advice is to stop the prophylaxis during that acute infection. Once it's resolved, then reinitiating that. However, if they're still getting recurrent UTI, so that meeting the definition of 2 in 6 months, then clearly prophylaxis is not being effective. So at that point, it doesn't seem to be effective, so it'd be worth stopping. Obviously, you would treat the acute UTI as we've talked about. Again, the importance of urine culture is important as well. And this is probably at the stage where you'd want to be thinking about referring to secondary care, as clearly the prophylaxis isn't helping. Okay, and then this is our final scenario. So it's Busola Akinwale. She's a 40-year-old premenopausal woman. Unfortunately, recent MSU has shown that she's developed resistance to trimethoprim, and she's also got CKD. And so obviously that limits our options in terms of nitrofurantoin is no longer an option as well. So some challenges around which antibiotics we can use in Bisola's case. So again, providing a bit more information around Bisola. So as I said, her second UTI in the last 6 months, as in the previous cases, is practicing personal hygiene measures and is not under secondary care. It's not using anything over the counter, has taken the full courses of antibiotics, and the UTIs have resolved. Understandably, she's concerned around the fact that she's got a further UTI, and also she's developed trimethoprim, and with the previous one, she had treatment failure because of that resistance that we've talked about on the MSU. And there is also this concern because of her CKD and how that impacts her treatment options, but she is keen to try and prevent her UTIs because she's really struggling during these UTIs, having to take time off work, sorry, and obviously she's struggling to be able to afford that as a result. So with this final poll again, so 4 options again like previous. So in Bisola's case, would you think about methenamine, the trigger or single dose antibiotics, as we've talked about, daily prophylaxis, or finally referral to secondary care? Could we launch the final poll, please? Excellent, thank you. So yeah, just take a couple of seconds to see what you think in this final case. Okay, so with this one, so majority have gone for referral to specialists, so 43%, followed by methenamine at 27%, trial of single dose or trigger related antibiotics if there's an identifiable trigger, and then 8% the trial of daily prophylaxis. Okay, great, right. So again, like the previous cases, you would obviously treat this acute infection, particularly taking into account the results of the previous culture that we talked about. It may be in this case because obviously the limitations in terms of the antibiotics, obviously as she's premenopausal, vaginal estrogen wouldn't be an option. You may want to be thinking about methenamine in this case prior to kind of antibiotics potentially, but it's a discussion around that. But the guidance would generally say around possibly a trial of methenamine at this stage, particularly because the self-help measures haven't been effective. So talking about methenamine or Hiprex, it's taken BD in catheters. It can be increased up to TDS, but generally that would be guided by our colleagues in secondary care. In terms of contraindications, the main one relevant to us in primary care is gout, and generally side effects are uncommon. Most common ones being fairly similar to lots of medications, so kind of gastric upset and skin reactions. And on the right is a summary of the trial that I kind of alluded to a little bit earlier. So a trial done in secondary care in the UK. We're essentially comparing methenamine to antibiotic prophylaxis and found that it was as good as prophylactic antibiotics at reducing recurrence. The other thing to bear in mind is the population of women in this study did have significant number of UTIs. So on average, they were getting about 7 prior to entering the trial. The other thing to consider with methenamine is, I know through speaking to various colleagues around the UK, is that in some localities, it's not on the formulary or guidance for use in primary care. It's changed where I work locally in the last 12 months. So maybe something to speak to your local medicines management team in view of this guidance to see if that could be incorporated. The other thing which I should have touched upon a little bit earlier is how methenamine works. So it's a urine antiseptic and does require urine to be acidic. And so some people may take things over the counter that can try to prevent or treat infections that make the urine more alkaline. So generally, if they're taking methenamine, it's advised to not take them. But also in the guidance, it also says that we don't generally need to prescribe something to try and acidify the urine, because in the majority of people, the urine will be acidic enough to be able to allow this to be effective. This is another study, and I really like this study. I think it's quite a clever study. So it's based in Norway, where they've been using methenamine for quite some time. And in 2019, they had a shortage, essentially for 4 months. And the researchers in this study took advantage of that, essentially, to see how effective methenamine was. So on this left-hand graph, you can see basically the use of methenamine, so prescriptions over time, it steadily increased. And between these two lines, I don't know if you can see my pointer or not, between these two red lines, this is where the shortage happened. And then on figure 2, on the right-hand side, this is the number of prescriptions for UTIs within those users. And prior to that kind of that shortage, that 4-month shortage, you can see that on average, the number of UTIs had declined. But during that 4-month period, the UTIs suddenly started creeping up. And again, when shortages were no longer a problem, the number of UTIs then dropped again further. So again, providing some more evidence that the methenamine does appear to be effective at reducing UTI recurrence. In terms of some more evidence to maybe convince you around methenamine, Cochrane review has also shown, published a couple of years ago now, but it's also shown potential benefits of methenamine in those without urinary tract abnormalities. We've obviously talked about the trial published in 2022. And then a subsequent systematic review looking at 11 studies in older patients who are over 60 found that methenamine extends that time between UTIs from 3 months to up to 11. So again, some more evidence that methenamine does appear to be effective. In terms of reviewing people on methenamine, if you to initiate, generally the advice from the guidance is to review within 6 months. Again, like we've talked about so far, to identify, are they getting any UTIs on the prophylaxis, and identify if they're getting any problems or side effects. It may be at that stage having a discussion around whether to continue or trial stopping the medication, but obviously continuing all of those things that we've talked about so far. And if they were to recur after stopping the methenamine, then it may be a case of considering restarting it. Obviously, seeking advice from specialist care if need be, particularly if the methenamine doesn't seem to be effective at reducing the recurrence rate of UTIs. Okay, so in terms of the main take homes, and from what I've talked about for the last period of time, so key things are recurrent UTIs, significant impact on patients and their well-being. We know, obviously, long-term antibiotic use can increase the risk of resistance, and obviously concerns around side effects, particularly nitrofurantoin. As we would do with lots of chronic conditions that we manage in primary care, it's around having discussions, shared decision-making, discussions around treatment, and this kind of stepwise approach to managing recurrent UTIs, taking into account this updated guidance from NICE last year. There are things that patients can do themselves around self-care, particularly with evidence around hydration, but it's just being mindful the evidence for some of the other things like hygiene, evidence is more limited, and just being sensitive around those discussions because they can be upsetting to patients. We've also talked about the NICE guidance around the potential use of vaginal estrogen, and talked about the evidence for that, as well as methenamine and the preference to use both of these generally before considering daily prophylaxis. We've also touched upon some of the key groups that generally we should refer or seek advice from secondary care. And also we've touched upon kind of single dose or trigger related antibiotics in this population. And actually, potentially the exposure to antibiotics is lower with that, and so reduces those risks of side effects and resistance. Thank you for your attention, and I'll stop talking now and hand back to Emily.
Excellent. Thank you so much, Lee. And we've had so many great questions in the chat, so thanks to all of our panelists as you've been responding to those. So I'll ask all of our panelists to come off, to put their video on and to come online. And then Lee, if you can stop sharing the slide, hopefully be able to see everybody on the screen. Great. Okay, so I'm going to start with a question for Philippa, if that's all right. So Philippa, we've had quite a lot of questions about vaginal estrogen use. And what you would do, I think you already responded to this question, but we're wondering if you can talk a little bit more online about what would you do if the twice weekly regime was not making any difference to UTI symptoms? Would you increase the dose or would you try something else?
So I can't really comment on the increased dose of vaginal estrogen, and I think that actually that may be perhaps Lee can comment on that. But in terms of what we would normally do if we think that actually there's an adequate dose of vaginal estrogen would be to consider what happens next. That may be around methenamine, which is in the NICE guidance, but I am aware is not necessarily on local formularies, and the potential for use of methenamine may be quite costly across health economies. And certainly locally to our system, it's a business case because we are talking about so much money. So the availability of methenamine varies, I think, from system to system. Generally speaking, where it's been started by a specialist, then I think it can continue in primary care. But there is a lot of it's going to have to be a question locally. I do think that the patients need to be looked at in terms of whether they appear to have a persistent UTI with the same organism, same antibiogram, or whether they seem to be getting different UTIs with different organisms on a recurrent basis, because the persistence of what seems to be the same infection may be about a longer treatment course of antibiotics rather than looking at things like methenamine, which would be antibiotics, if you use them in people who are getting recurrent UTIs with different organisms, may simply affect the resistance profile of the gut flora, which is then causing those recurrent organisms and essentially drive a cycle of resistance. And so with those patients, I would be looking to consider what are there underlying causes for these UTIs, but to consider methenamine on top of the vaginal estrogen rather than antibiotics.
Thank you for
Yeah,
that. Lee, please chime
sorry,
in.
I mean, I was just
No, go for it.
I was gonna chime in as well. I was gonna say I think that the thing with vaginal estrogen is that it's not going to work instantly. It's going to take a bit of time to work. I think, as you've said, Philippa, I think in that case you may want to add in methenamine, but then potentially when things are controlled, you may then want to pull back on the Hiprex or the methenamine and continue the estrogen long term. But I'm not aware of any kind of evidence or guidance around kind of increasing that dose. It may be having a discussion about the form of estrogen, speaking to patients. Some get on better with tablets, some get on better with cream. So it's maybe just having that discussion. Is it the formulation that's the issue? And then maybe not using it effectively. So it's having that kind of discussion.
Fantastic. Thank you. Naomi, I have a question for you that maybe you can respond to. So I think Philippa touched on this, but a number of people are asking about how methenamine is read in a formulary or it's not recommended by the BNF at the moment. So can it still be prescribed? And I was wondering if you can talk a little bit more about that. Sorry, did you hear me, Naomi? Oh.
As we know, recently been updated, and it is, I think, yes, sorry, did you hear me?
No, that's okay. We can hear you now. You're good.
Okay, great. So yeah, as the NICE guidance has only recently been updated, it may be that some meds optimization teams are either not aware or are still going through the process to get the formulary status changed. So it may just be a lag, but please do chase your medicines optimization teams at the ICB just in case they're not aware of this change in NICE guidance. But most of the ICBs that are aware have either gone through the process to change the formulary status or are doing so. And we at NHS England are also in discussion with the BNF editorial team to change the wording. So it is clear that methenamine can be used for prophylaxis of UTIs.
Thanks, Naomi. Avril, I have a question for you. I don't know if you can come off your video, put your video on or not, but here we go. So a question about breakthrough UTIs and how to base the choice of antibiotic to treat an acute infection. And also if you can clarify if they're on a certain antibiotic prophylaxis, can they have the same antibiotic, but for what treatment for what treatment dose?
So I've looked into that very point. So I would say that you should not use a treatment dose of the same antibiotic that the patient is taking prophylactically. The likelihood is that their breakthrough UTI is because of resistance potentially to the prophylactic agent. So by giving them a treatment dose of that same antibiotic, would not be optimal in that case. And in terms of what antibiotic you should use, potentially taking an MSU at that point, a midstream urine for culture, would be really useful, both in terms of knowing what organism is present to treat it appropriately, but also potentially to be able to review the prophylaxis, because if it comes back that the patient is resistant to the drug that they are taking prophylactically, that is an excellent time to consider reviewing their antibiotic prophylaxis regime. Hope that helps.
Thank you. Does anybody else want to chime in there, or I'll ask another question? Okay. All right, Lee, I have one for you. This is about oh, sorry, Philippa, do you want to chime in?
Yes, I just thought it would be worth mentioning that that is a strategy that is used by one of the London clinics, which for recurrent UTI, which some patients get referred to. So they have a tendency to put an awful lot of patients on prophylactic caprolactin and then increase the dose with a flare of symptoms, so that you may have come across patients who are on this.
Thanks, Philippa. All right, Lee, I have a question for you. Can you talk about whether or not vaginal estrogen would be suitable for premenopausal, perimenopausal, menopausal women and the different groups?
Yeah, of course. So yes, I mean the updated guidance talks about the potential benefits in perimenopausal and menopausal women as well. In terms of premenopausal women, that's not one of the populations that it talks about, and I'm not aware of any trials that specifically have looked at that population of women. So I generally wouldn't prescribe it for premenopausal women, but definitely for kind of perimenopausal and postmenopausal women. And you've got the added benefit that it can help with some of the vaginal symptoms as part of the menopause as well.
Thank you for that. Naomi, here's another question for you. So let's say we have, this person was asking specifically about clinical scenario 1 with mailing. And it was just, I think you responded to say if there was limited improvement in 3 to 6 months, would you go for a dual therapy of estrogen and nitrogen and possibly repeat based on episodes? Did you want to talk a little bit more about your response to that question?
Yeah, so if there was limited benefit and the patient was still having recurrent UTIs out of frequency that impacted on their lives, then the next stage in NICE guidance is for a single dose antibiotic after a trigger. People have different triggers. The obvious one that we most think about is post-sexual intercourse, but there are others. So in the guide, we have included a diary so people can note down what they're doing and identify their own triggers, and then therefore they get the single dose, one-off dose prophylaxis, which reduces the risk of antimicrobial resistance and side effects from antibiotics, but still gives them the benefits. So that's what I would suggest as the next step. And carry on using the vaginal estrogens if that helps with their other menopausal symptoms like vaginal dryness. So yes, I suppose is the answer to that, but it would be a single dose prophylaxis rather than long-term nightly prophylaxis.
Fantastic, thank you. Lee, and I guess any of the other panelists who would want to chime in, we've had a number of questions about cancer and referring for suspected cancer. And, we have the NICE guidance, which provide very detailed kind of criteria, but then you look and sometimes doesn't seem quite as specific as you'd like. So would you like to just talk a little bit about your experience and when you would consider referring different groups, different patients for cancer evaluation?
Yeah, it is difficult, and I always have to go back to the NICE guidance in terms of the specifics around the guidance for this. I think that the key one is hematuria is the main thing that we're kind of looking for that, and particularly if women are presenting with UTIs and they've got hematuria, whether that's visible or non-visible based on dipstick, the importance of just making sure that that's resolving. Appreciate that there's challenges to doing that, but it's just making sure that after they've received treatment, that hematuria is resolved. Because if it's not resolving, that would be a more concerning feature. Again, they obviously the risk of particularly bladder cancer is the thing that we're particularly concerned about is thinking about that in older women, and I guess part of the guidance around those ones that are not responding to these various prophylactic treatments. If they're not responding, that's why we should be seeking kind of secondary care, thinking about, do we need to go down the route of things like cystoscopy? Can obviously arrange things, and I've done this in terms of ultrasounds and things. You can arrange some of those in primary care in certain populations as well.
Fantastic, thank you. Anybody else want to chime in on that one? Or else I have another question to ask. This one is about self-start antibiotics. And Lee, if you want to respond to this one, also Avril, Naomi, or Philippa, if you want to chime in. But if the questioner is asking, if we can explain a bit more about self-start antibiotics, how long can we issue self-start antibiotics before reviewing, and how are these used for patients who are known to have triggers for UTIs?
I can come in on that one.
Thanks,
So there was a Chinese study, Zhong et al., which showed that a treatment dose antibiotic at the point of known trigger was as effective as prophylaxis in reducing in symptoms. So if we can discuss with patients what their triggers are and patients can identify those, then taking that trigger antibiotic at that point can be really effective to manage the symptoms accordingly.
Yeah, I was also just going to chime in if that's okay, Emily.
Please.
And it's also thinking, because I think in the question that it felt like it was two parts. So obviously you've got self-start where you're potentially thinking about trying to support someone coming off prophylactic antibiotics, so giving them essentially like a rescue pack of antibiotics. I mean, obviously an individual case, but that's generally particularly to support people coming off. But as Avril has talked about, the use of kind of single dose, it's in those patients that have got a kind of clear history of a trigger and the benefits. Personally, I've seen it be quite effective in certain cases that I've seen in general practice. And the benefits is that obviously if people are getting recurrent infections and they're getting long courses of antibiotics, overall you're trying to reduce the burden and the overall kind of antibiotic burden that they're getting. So it can be a useful strategy in those patients.
Fantastic, thank you. Does anybody else want to chime in on that one? Great. Otherwise, we are pretty much at time. So I can't thank Lee for your presenting. Thank you so much, and all of our excellent panelists for joining in. Really appreciate the discussion, and thank you all, the participants, for joining. So I hope everybody has a good evening, and yeah, thanks again.